So welcome to this discussion about the healthy adipose tissue and its role in insulin resistance and type 2 diabetes. My name is Ulf Smith and I'm a professor of medicine at the University of Gothenburg in Sweden. And I have two leading experts in this field with me, and on my right I have
Marja-Riikka Taskinen, professor in medicine, University of Helsinki, Finland.
And on my left,
Dr. Mike Jensen, endocrinologist at Mayo Clinic in Rochester, Minnesota.
Certainly names well known to everybody working in this field and interested in this field. So we're going to talk about healthy adipose tissue and some recent work or recent knowledge, I would say, that means and tells us that the subcutaneous adipose tissue is quite useful in terms of storing the fat, but that there are limitations to how much of the fat we can store in subcutaneous adipose tissue. And then the problem seems to be escalating. And I would like to ask Mike Jensen to comment, what happens when we overload the subcutaneous adipose tissue with this, living in this affluent society that we are?
Well, it seems like there's a lot of variability in what it takes to overload adipose tissue, but certainly at some point most people are going to run out of the capacity for their subcutaneous fat to store and release fat in a normal manner. And when that happens, that excess fat is going to end up being stored in other places where it's certainly a lot less healthy than when it's stored in subcutaneous fat. It can end up in your visceral fat, it can end up in liver, in muscle, in places where those fatty acids can have some toxicity.
You have recently published a study where you overfed individuals to see what happens when we eat too much. And you published some very interesting results in terms of the ability of fat in different depots and stores to, as it appears, crosstalk with each other. Do you want to comment on these studies?
Yeah, it's interesting. It appears that for most of us, when we gain fat in our upper subcutaneous depot, we gain it primarily by increasing fat cell size, and we're just gaining a few kilos or so. But even gaining a little bit of fat in the leg fat area seems to be mostly by recruiting new fat cells. So we end up, even with as little as 1 or 2 kilos of fat gain in the lower body fat, you can generate billions of new fat cells within a period of a few months.
So this is very interesting because we know that as the abdominal fat cells expand and become like balloons, inflated, that this is negative and leads to what we call ectopic lipid accumulation in other stores like the visceral and the liver, which we'll get into later. But it also seems that there is an ability to crosstalk then. So if we cannot recruit more fat cells in the abdominal adipose tissue, there is an opportunity, at least for some, to increase the lipid storage and recruit new cells in the gluteofemoral region. Is that correct?
Right, and what we're not sure of is that those people who are really able to recruit new fat cells well in their lower body, that sort of protects them from having to expand the size of the fat cells in their upper body. It seems to be the most likely explanation is that some people are just very good at making new lower body fat cells, and therefore they don't have to make their upper body fat cells bigger.
This is very interesting because I think everybody knows that what we call the waist-hip circumference ratio is a risk factor for cardiovascular disease. In fact, very big studies like the Interheart study has shown that this is probably the best predictor of risk for cardiovascular disease, not just the waist circumference, but also the hip ratio. But if you just look at the hip ratio, not the hip circumference ratio measurement, it actually appears to be protective, while the waist circumference is negative and the risk.
Right.
So these results could then tell us something, that people who have the opportunity to put fat in the gluteofemoral depot are more protective than the ones who cannot do this.
Yeah, it seems like maybe they've got really good pre-adipocytes, really good stem cells able to proliferate, differentiate, and store fat in a more healthy manner.
Because the concept is that we cannot recruit new fat cells in the abdominal site, but then if we can recruit them in other sites, that may then help the healthy storage and have healthy adipose tissue. Correct?
Correct.
Now, if we are unable to store fat in the subcutaneous depot and they start to accumulate in the visceral fat, in the liver, and as it appears also in skeletal muscle, or even worse in the heart, in the myocardium. But what happens with this fat that we accumulate in the liver? What are the consequences of this, what we call liver fat accumulation?
This fatty liver disease, as we call it, is becoming more and more prevalent because there's more and more obesity around. We have the global epidemics, and the storage of fat in organs where it's not supposed to be stored is then the rescue way for deliver this extra fat. And of course in liver it has several adverse consequences, because the fatty liver is releasing several cardiovascular risk factors. Of course, it is very closely related to the production of the lipoprotein particles, particularly those which are carrying the triglycerides, and is also responsible for the elevation of plasma triglyceride levels. And this has consequences on other lipoproteins, LDL size, as well as the good cholesterol, the HDL cholesterol, which will be reduced. So you will get a combination of the so-called atherogenic dyslipidemia, which is a major cardiovascular risk factor, particularly in those people who have achieved LDL targets being treated with statins, for example. In addition to that, the liver releases also many of the inflammatory markers which are released as a response to crosstalk between the adipose tissue and the liver, and also several factors which regulate the thrombosis. That means we have a picture where you have the atherogenic dyslipidemia, you have atherothrombotic profile in your circulation, and also markers of the inflammation, which indicates that there's inflammation in the liver, which is fatty.
Could I ask you, could I be pointed then? Would that mean that the increased triglycerides and the VLDL triglycerides that we see in overweight individuals, obese individuals, is that also a marker of the attempt by the body to get rid of fat, or to overflow of fat, including into the bloodstream, as a consequence of not storing it in the subcutaneous adipose tissue?
Correct.
adequately?
It's also a tool to get rid of the extra fat in the liver, because as I said, if the fat is stored in the liver, there will be a cascade of events leading to the inflammation in the liver, and also changing the lipid composition in the liver, and all these will be adverse effects and harmful. So liver tries to get rid of extra fat, and as long as it can secrete it as VLDL particles, fine, because then once again these will be circulated back to the adipose tissue. A part of the triglycerides are taken up by the adipose tissue, hopefully.
So would it be fair to summarize the discussion that if we can store the excess fat that many of us eat too much of and accumulate in the subcutaneous adipose tissue, but if we can put it there, it may be considerably less harmful than when we reach the upper capacity of a subcutaneous fat, and it gets into the visceral, it gets into the liver, it gets into many other sites, including the myocardium, which we will return to discuss about at a later time. Thank you.